Okay, welcome and thank you all for attending today's briefing. Let me introduce myself. I'm Bill St.Clair. I'm a rheumatologist. My home is in Durham, North Carolina, and I work at Duke, home of the Blue Devils, right, Tim? Hope there are not too many Carolina fans here. So I practice rheumatology, and I'm also currently president of the American College of Rheumatology. And the ACR is our subspecialty professional organization, and it's home to virtually all rheumatologists in the United States, but we also include among our members physical therapists, nurses, nurse practitioners, PAs, physical therapists, pharmacists, occupational therapists, just about all the specialties, all the other providers who care for patients with rheumatic diseases. We're a relatively old organization. We were founded in 1934, and currently we have more than 9,500 members. So we convened this briefing with the Arthritis Foundation and the National Psoriasis Foundation to raise awareness about rheumatic diseases and the current shortage of specialists who care for our patients, including children with juvenile rheumatic diseases, including juvenile arthritis. In just a minute, I'll introduce Arthritis Foundation's president and CEO, Ann Palmer, who's with us today. And Ann is head of the foundation, which is leading the fight for the arthritis, and a strong patient advocate, and promotes life-changing information and resources, access to care, advances in science, and community connections. And their goal is to, like ours, is to chart a winning course and make each day another step towards a cure. So the National Psoriasis Foundation was founded in 1968. It's a nonprofit organization whose mission is to cure psoriatic disease and improve lives of those affected with this illness. Randy Baronic, President and CEO of the National Psoriasis Foundation, is right here, smiling. And in his role, he drives the foundation's strategic direction in pursuit of its mission and the needs of the psoriatic disease community. And I'll say right now, we're already, we've had strong interactions with the Arthritis Foundation in the past. We've been together for many years, and now we're starting to interface with Randy and his group. So under Randy's leadership, the foundation has enjoyed unprecedented growth, and both in providing support to patients and also supporting research. So prior to joining the foundation, I learned that he served with the American Heart Association and the American Diabetes Association. He's currently chairman of the board of the National Health Council. So many of you may be wondering, what is a rheumatic disease? I can also look around and suspect many know a lot about rheumatic diseases. A few examples. Rheumatoid arthritis is probably the most common chronic inflammatory disease that we see in clinic. We also take care of patients with lupus, systemic vasculitis, ankylosing spondylitis, and pediatric rheumatologists take care of patients with juvenile idiopathic arthritis, the pediatric spondyloarthropathies, and many other diseases. Currently, 63 million Americans, including 300,000 children, are living with arthritis or a related condition. And without access to care, these diseases can continue to run rampant, cause pain, progressive joint damage, eventually disability, which also has an impact on their ability to carry out their normal activities, the ability to work and enjoy life. So rheumatologists specialize in managing care for patients with these diseases, but unfortunately there's a workforce shortage, and we're now faced with a number of access issues where many patients, including children, are just not simply able to access care when they need to. So what I think is really exciting today is that our panelists will discuss with you their own personal experiences with rheumatic disease, and what you, as policymakers, can help to ensure that they have continued and even more access to care, both for adults and children. So finally, I'd like to introduce Ann. Ann's going to be monitoring today's discussion. As I said earlier, she's president and CEO of the Arthritis Foundation. And Ann joined the foundation in 2013, and she had a substantial amount of experience in her other jobs. She had held leadership positions at the American Cancer Society, the American Diabetes Association, where I think, did you guys run into each other then? Okay, good. And the Cystic Fibrosis Foundation. And I've had a chance to really see Ann at work, and she's done a terrific job really reviving the Arthritis Foundation, so I applaud her for these efforts. So I'd like to thank everybody for coming today, and without further ado, I'm going to ask Ann to come to the podium, and let's get this thing underway, okay? Thank you.
So welcome, and thanks for being here with us today. And I think that now our goal is to really talk to you and have you see what the impact of a shortage of pediatric rheumatologists means. And so I'm going to kind of have you think for a minute. How many of you have been on a long car ride with children? Have you been on a long vacation? It kind of starts out good. Maybe you have some snacks and some games, and maybe you're playing I Spy or watching some video games. Gets a little long, starts to melt down, a little whining. Pretty soon it's awful. Well, imagine that ride with a child with arthritis. 8 hours in the car, but you're not going to Disneyland. You're going to see the doctor. 8 hours or more. That's what we're talking about here. The fact that for many parents, they have to take their children very long distances, and they have a child in the car with them that's in pain. If you're a parent, or if you haven't experienced this yourself, or at least you've been on a plane with someone, you know what this must be like. So what we know is that there's a shortage of rheumatologists and specialists, and there's a significant shortage that means that our patients aren't being able to see these people. And I want to tell you a personal story about my first experience attending a JA conference. And over here we have a little poster from our most recent JA conference where our children put their thumbprints there. So I brought that along just to show you that this is real. This is real people. But my first conference, we were here and we were doing a summit, and we had some specialists come in to meet with our children and to have them be able to articulate what they'd like to talk to congressmen about. And they came back and they presented me with this poster, and they had 3 key messages. We want a cure, we want less pain, and we want more doctors. Now, can you imagine? These are 3- and 4-year-olds who are talking about that they want more doctors. So that's what this is about today. I just think that this is a devastating disease for a family. Complicated, long, difficult disease to live with. In this day and age, certainly we shouldn't have to subject families to a shortage of pediatric rheumatologists. So today, we're going to listen to 4 great panelists tell some stories, and I'm going to just tell you a little bit about each one of them, and then they'll tell their story. So first is Andy Moy, and he's a high school senior at Waterford High School in Michigan, and he's a youth ambassador for the Psoriasis Foundation, and also an honoree for the Arthritis Foundation Walk. So we're glad to have you with us. And on the end is Joy Ross, and she's an advocate for the Arthritis Foundation. She has JA and uveitis, and she is also the mom of 2 beautiful daughters who also have JA and uveitis, and with her is her helper, and George, who you'll see is a great supporter to her. Then we also have Dr. William Harvey, who is a board-certified internist and rheumatologist, and he practiced at Tufts Medical Center in Boston. And finally, Dr. Hendrickson, board-certified pediatric rheumatologist who practices in the Division of Rheumatology at Cincinnati Children's Hospital Medical Center. So first, I'm going to start with Andy, and I'd like for you to start, Andy, by just telling us a little bit about your story.
All right. Good afternoon. Good afternoon, and thanks for this opportunity to speak today. My name is Andrew Moy, and I'm 17 from Waterford, Michigan, which is about an hour from Detroit. Right. In many ways, I'm a typical teenager. I like to hang out with my friends. I'm part of school organizations like Yearbook and my robotics team. And then I also like going to music events. But the one thing that makes me different from the rest of my classmates is I have juvenile psoriatic arthritis. I've been diagnosed with psoriasis at the age of 4, which for those who do not know about psoriasis, it is a disease that makes my skin red, irritating, and it will occasionally crack and bleed. And then a year later, I was diagnosed with arthritis. Yes. Because my primary doctor wasn't able to fully understand what I was going through, I was referred to a specialist, a rheumatoid doctor who specializes in pediatrics, and she didn't quite understand what was going on with me. She was visiting many of her patients, and a lot of her patients took up a lot of time. She prescribed to me Motrin, which didn't really help. And because of this, I went with going through Motrin for a long time, but the effects wound up me having disformed hands and a fused hip. After a few years of taking Motrin, I was finally referred to a doctor, or a pediatric rheumatologist, that was able to finally figure out what was going on and prescribe me the right medication. But sadly, the damage is already done. It took 6 months to get a doctor's appointment to see this one doctor. Generally now, I see this one doctor about 3 to 4 times a year, planning months in advance. I'm not the only one like this. I have many friends that also have juvenile arthritis that have to plan and even farther ahead, and also have to come from hours away, many hours, sometimes even out of state, just to see one doctor for 1 hour doctor's appointment. More fun, but we need your help. Arthritis is one of the #1 causes of disability, and it can do irreversible damage. But by supporting funding, it will increase the number of pediatric rheumatologists across the country. And also, it will allow better access to care to prevent irreversible damage and better medical treatments available to help with the painful options. And hopefully, after all of this, there will be a crucial better outcome for all juvenile arthritic patients. Thank you.
So we'll have a little time at the end for questions and answers. So Andy, thank you, and we'll get a chance to ask him some questions later on. So thank you. So Joy, would you like to share your story briefly with us too?
Hi, everybody. My name is Joy Ross. It's such an honor to be here. I'm from Camas, Washington, and I am completely blind. I was blinded by juvenile rheumatoid arthritis. Arthritis of the eyes is called uveitis, and I was diagnosed at the age of 3. So our family was living in Arkansas at the time of my diagnosis, even though I didn't get my diagnosis in Arkansas. So my mom one day was looking at me. She told me the story. We were driving in the car one day, and she looked over at me, and she saw the sunlight caught my eyes in a certain way, and she said that my eyes just didn't look right. She said my right eye looked more cloudy, not as glossy and shiny as my left, and I was light sensitive, and so she took me in to see an ophthalmologist, and just a regular ophthalmologist in Arkansas. And the ophthalmologist looked at my eyes, and he said, "Something's wrong. I don't know exactly what's going on with your daughter, but it's not a common thing, I guess, that he's used to seeing. He did recommend for my parents to take me to see a specialist in New Orleans at Ochsner's Children's Hospital in New Orleans. So my family took a whole month off, went and traveled to New Orleans, and we stayed there and until we got the answers that we were looking for. The doctors told my parents while we were there, after so much testing, your daughter is going blind. Okay, they said your daughter's going blind due to juvenile arthritis. My parents had no idea that kids could get arthritis. They didn't even know that it could cause blindness, right? And now they're being told that their daughter has got arthritis of the eyes, but she also has, now they found out I have arthritis in my joints by the age of 3. The arthritis in the eyes was so chronic, I didn't see anything out of the right eye, and I barely could see a lot out of the left eye. I could see basically the big E on an eye chart. From that point forward, my parents did everything they could to get me into the doctors. There was no pediatric rheumatologist in Arkansas, and still today, there's maybe one pediatric rheumatologist in 2015 in the state of Arkansas. So I got treated with oral steroids and steroid eye drops. That was all that was there for me at that time. And by the age of 5, underwent cataract eye surgery on both eyes. And then as I got into junior high, my arthritis became more involved in my joints. As I moved into high school and college age, it became so debilitating that I had to drop out of college. So on top of the joints, on top of the eyes, you know, it was very difficult for me, but I powered through. Moving forward, I met the love of my life, my husband. I met him on a blind date. Ha, you're supposed to laugh. And after we were married, we talked about having children. One of our concerns with having children was, am I going to pass this down to my kids? Doctors told me it's a bit like a 1 in a million chance you could pass it to your children. And I was like, okay. I knew I wanted to be a mother, and so we went ahead and had our babies. And fast forward, after our babies were born, to 2008, they were 2.5 and 5. We were doing this road trip from Portland, Oregon to Texas, and I lost all of my vision at this time in my left eye, and I absolutely was living in darkness. My girls were both diagnosed in the next 6 months with juvenile arthritis, both of them at the same time. So for our family, it was devastating, but the wonderful news, though, if there was any wonderful news to be told, is we were living in Fort Worth, Texas, where there were doctors. That was so different from when I was diagnosed. It was a different world. Did you want to ask?
You're great. That's perfect. Thank you. I think we'll have some more questions for you later on, so thank you. So next we're going to hear from the doctors, and I think we're going to start with you, Dr. Harvey.
Thanks very much, Ann. I'm Will Harvey. Sure. Thank you. I'm Will Harvey, and I'm the clinical director of the Arthritis Treatment Center at Tufts Medical Center, and I'm privileged to chair the ACR's Government Affairs Committee. So first I want to thank Joy and Andy for sharing those stories. It's remarkable and heartbreaking to hear the issues that they have dealt with in struggling to find a diagnosis and in struggling to find a treatment. As Andy mentioned in his remarks, we are facing a critical shortage of rheumatologists, especially those who are specializing in pediatrics. While there are more than 300,000 children diagnosed with juvenile arthritis in the United States, there are currently fewer than 350 board-certified practicing pediatric rheumatologists to serve these children. Many of these specialists, furthermore, are clustered around large cities or at academic medical centers. They spend significant portions of their time doing research to try to find new treatments, which limits their the hours that they see patients as well. Currently, and these numbers fluctuate because to serve this population, a lot of these physicians will move around from institution to institution. There are roughly 9 states that do not have a single board-certified pediatric rheumatologist. That's none in the whole state. That's practically a fifth of our country. And 7 states have only one practicing pediatric rheumatologist. So unfortunately, the stories that you just heard are entirely too common today in the United States. Because of this severe shortage, a large majority of juvenile rheumatic disease patients seek care from general pediatricians who are not adequately trained to care for children with rheumatic disease, or they come see pediatric adult rheumatologists like me who are not trained to see kids. That almost always results in suboptimal care. We do what we can, but it's not right, and it doesn't have to happen in this country. Occasionally, like Andrew described, those who are able to see pediatric rheumatologists do not receive an adequate diagnosis or treatment due to issues such as high patient loads and decreased amount of time that we're able to spend with our patients. And that is also quite a shame. Our population is aging and people are living longer lives, so the demand for rheumatologists, both pediatric and adult, is not really expected to decrease anytime soon. I have a somewhat unique position as an adult rheumatologist that, and I'm fortunate to practice in a place that does have pediatric rheumatologists. I actually administer a transition clinic, and what that clinic does is transfer patients when they reach the age of 18 or 21, depending on the person. They transition from the pediatric rheumatologist to the adult rheumatologist, and we end up taking care of them. And there are 2 groups of people in general that come to see me in that transition clinic. There are people whose disease was caught relatively early or was mild, who got effective treatments, and you might walk past them in the street and never know that they had juvenile arthritis and now are an adult living with juvenile arthritis. Unfortunately, there's another group of people. These are the folks who had their diagnosis delayed, who ended up with permanent joint damage, who ended up with blindness, who ended up with all the other complications that can come from these diseases. And as Andy pointed out, once the damage is done, it's very difficult to reverse it. So I just want to tell you about one patient. For the purpose of today, her name's Karen. She's kind of famous around Tufts, and what she does, she's now in her 40s. She had juvenile arthritis as a child. She did not get treatment very early, and she was treated primarily with steroids, which cause a significant number of terrible side effects. And she has spent the last 15 years coming to Tufts to teach medical students. And she comes and brings her daughter, who also has juvenile rheumatoid arthritis. She is wheelchair bound. She has arms and legs which are a little bit shorter than others because the arthritis can affect the growth of the normal growth of the bones. And so she's confined to a wheelchair. And she stands there with her daughter, who is not confined to a wheelchair, who will walk around the room and talk to the students. And the point there is it illustrates what the massive difference is. When she was a child, when she was treated, she was unable to prevent the damage that occurred. Her children are living in a different era, and they are living in a time when we can intervene and we can help them. So the average pediatric rheumatologist is now in his or her 50s and rapidly approaching retirement age, and so we need to ensure that the next generation of doctors have enough rheumatologists to adequately care for their growing patient base. Coping with rheumatic disease is no walk in the park, but with proper care and treatment, many patients with rheumatic diseases can live active and fulfilling lives. The stories that you heard before you do not have to happen. I will just end by saying I have a little fork on my lapel. You might be able to see it. It has some bent tines, and it signifies 2 things. One is that when you have arthritis, even simple tasks like using a fork can be incredibly difficult. Also, its bent nature kind of signifies what can happen to someone's hands if they're untreated with these arthritic conditions. And so as I like to close by saying, we need help unbending the tines of that fork. We can stop this from happening. We need great treatments, which we have more and more of now, and we need rheumatologists who are trained to administer those treatments as quickly and early as possible for these patients. Thank you.
Thank you, Dr. Harvey. So Dr. Hendricks, we'd like to hear from you as well.
I'm Michael Hendricks, and I work at Cincinnati Children's, as you heard, and I'm also a faculty member at the University of Cincinnati College of Medicine. I salute Andy and Joy for being here. I think it takes tremendous courage, and I wish you had had a different experience It is part of the evolution in this country, and I hope you feel in the pit of your stomach some outrage at what you heard, because it should evoke outrage. We have a better country than what these stories portray. Living with rheumatic disease as a child is not only physically difficult, it also extracts a great deal of emotional stress as well. More than half of pediatric arthritis patients have to travel 100 or more miles to see a pediatric rheumatologist in this country. And for 65% of patients, the average wait time to see a pediatric rheumatologist is over 2 weeks. As Dr. Harvey mentioned, and Andrew discussed, early diagnosis and treatment is very important, but it's difficult for providers not trained in pediatric rheumatology to diagnose arthritis in young patients. With symptoms ranging from mild to life-threatening, proper management is critical. Furthermore, access to pediatric rheumatologists increases access to novel therapies, and therapies that are only available oftentimes in clinical trials. I was asked to provide some personal experience about 3 areas. One was my choice of specialty, why, also some challenges of pediatric rheumatology, and to provide you some notable examples where early intervention is critical, as if I have to say more than has already been said, but let me share some personal thoughts. I did my pediatric residency in the Army, and I saw an unmet need in pediatric rheumatology. I had several hospitalized and clinic-based patients with rheumatic disease, and it was clear none of my faculty had any experience with such disorders. In fact, I was urged not to spend an elective month training with a civilian specialist because, quote, I would never see these cases in practice, close quote. This was 1987. I've enjoyed the complexity of these patients, appreciated their patience in my efforts to practice at a frontier of medicine, to thrive on a team as we return patient function, and to be their advocates in a health system largely focused on acute care. Some of the challenges I've seen in pediatric rheumatology include the constant, and I mean constant, effort required to obtain resources for my patients. The most simplistic medicines that are tacitly approved for adult rheumatology patients require hours on the phone, these peer-to-peer consultations, many, many hours of writing letters just to get one medicine approved for a patient. That's time I'm not seeing patients in the clinic. Secondly, I would also reflect the exceptionally long hours required to do the work, which has often been a considerable sacrifice of my family life. I worked, as many of my colleagues have and continue to do, 24/7 for years to provide access to care for these patients. The third challenge I think that's quite constant is the public perception that biology is somehow different for children and that children do not get arthritis and autoimmune disease. Some notable examples where earlier intervention is critical. I want to impart to you that the achievement of developmental milestones is essential for a child's growth, for their capacity to participate fully in educational opportunities, and eventually to be employed. That is the goal. Providing an accurate diagnosis is vital, so precious healthcare dollars are not inappropriately spent on conditions a child or teenager may not have. How many patients have been sent to me with a diagnosis of arthritis that they don't have? We have a particular disease called scleroderma. It involves the skin and joints. If it's not treated appropriately, it can cause a great deal of disfigurement. That in turn creates a great deal of social ostracization and isolation for our patients. For arthritis, reversing advanced disease, as Dr. Harvey noted, takes an abundance of time and effort and resources and missed parental work days driving those long distances. Pam alluded to at the beginning. And so it's crucial that we ensure enough young doctors finishing medical school choose to specialize in rheumatology or pediatric rheumatology, and that more of these specialists open up their practices in rural and other underserved areas. I encourage you to ask your bosses to support H.R. 1859, Ensuring Children's Access to Specialty Care Act, which would include pediatric subspecialists like pediatric rheumatologists as eligible for the National Health Service Corps. The National Health Service Corps provides scholarship and loan repayment to healthcare providers in exchange for service in rural and underserved areas. And the bill would help children in areas with no pediatric rheumatologists have access to providers best suited to meet their needs. Access to care for all rheumatic disease patients is within reach. We just need your help to achieve it. Thank you for your time today.
Thank you. So I hope that you can see that the needs are real, and certainly as you listen to the rheumatologists, and certainly we see that every day, the dedication it takes, the extra dedication it takes to serve these patients' needs. So now we're going to do some follow-on questions, and Joy, I'm going to start with you and ask you about the differences. There have been some advances since your diagnosis and that of your daughters, and wondering if you can share with us what you think the difference might mean relative to their prognosis versus yours.
So we are very blessed. We were very blessed when our girls were both diagnosed, that we were living in a city, Dallas, Fort Worth, Texas, where our girls had access to care and to treatment. We also had the blessing, kind of a blessing. Well, I had been raised with this disease my whole life, so we knew kind of what to look for when when my oldest daughter, when we diagnosed, we found out that she had arthritis. She was limping on her ankle, and her foot was so swollen. As soon as my hands touched her foot, I knew it was arthritis. And and then when we took her in to see a doctor, first we took her in to get an x-ray, and their x-rays were fine. And we're like, I just knew this was arthritis, my worst nightmare. Took her into another doctor and did blood work. When the results came back with arthritis, it hit me. But then again, I'm going, but at least we caught it. As soon as it appeared, we caught it. And then when my youngest daughter, Georgiana, 6 months later, was in for her annual eye checkup, because after this one was diagnosed, we're like, we have to be on top of this for sure to catch if it could possibly affect my youngest daughter. Who would have thought that it would so quickly? And then my husband, George, took Georgiana in to see her ophthalmologist this one day. It was just annual, just regular checkup. And I remember the phone call. I remember it. He said Georgiana was diagnosed with uveitis. And in the moment where my husband and I were both devastated, right? I had just lost all of my sight in 2008 at the same time to this terrible disease. Now it's affected my babies, my everything, our everything. As we're frustrated and want to be angry, there was a part of me goes, I am so happy that my girls have a different outcome. They will have a different outcome than I had. I didn't have the treatments. I didn't have the care. There was no treatments available when I was a baby. But my girls have a different future. They have a different life ahead of them, which gave us hope. My youngest daughter, Georgiana, after she was diagnosed, I remember this one night, we were laying in bed together. And I wasn't lying to her. I told her the truth. This is the disease that Mommy has. It caused my blindness, And she said, Mommy, she goes, am I going to lose my sight like you? You guys, this is a serious disease. I don't want anyone to suffer. All of these children, they need hope. They need to have the care. They need to know that they can get there. I didn't have it. And I want you guys, I know you look at me and you probably think, oh, she looks fine and she's perfect. She's got her life all together, even though you see I have a guide dog on here and I tell you I'm blind. But this disease is real. I wear prosthetic eyes. These aren't even real. I want to show you. I have a real eye, so I'm not going to freak you out. But I want to show you. This is what this disease has done to me.
we were given. And I don't want this to continue because this is the damage the disease did. And there's no going back and changing it. And I've made peace, and I have found peace and joy in my life in the dark. But speaking to you today and sharing with you our family's story. Hold on, I'll put it back in real quick. It's what makes my life fulfilled. And it makes my life living in the dark worth it. Thank you.
Thank you, Joy. So Andrew, if you wouldn't mind telling us a little bit about how often you need to see a pediatric rheumatologist, and help us understand if seeing a pediatrician would be just as good for you or not.
Right. I see my rheumatologist about 3 to 4 times a month, and during these visits, since it is really crucial that I get to him, not only are we able to make sure my disease is in check, but we're also making sure it's not worsening, or like it has in the past getting better, so I can lower on my medication to prevent it from getting worse. Rather than going to a pediatrician, pediatricians would not have the detailed experience as a pediatric rheumatologist. They're more generalized, so they're able to help in everyday situations, such as if you're sick or you have a minor injury, but they will not understand arthritis at the level of a pediatric rheumatologist. And by seeing them like I do, it has definitely made a big impact. By seeing the right ones, I was able to make sure my condition didn't worsen to the point where I couldn't move on my own. On some days, I do need to use a wheelchair, but luckily, I'm able to walk most of the time. And if I were to only see a pediatrician about this and never saw an actual pediatric rheumatologist, I may have not been able to walk or write at all.
Thank you. So Joy, I think that you stay in contact with a lot of other moms and family members, and I'm wondering if you could share some of the common challenges that you hear that families have around access to care.
So I have a very close relationship with hundreds of families across this country. I'm on Facebook. I talk to them. I hear their stories all the time. Just this summer, we were at the National Juvenile Arthritis Conference in Orlando, and I had the opportunity to meet in person and hear these stories of the horror stories, actually, of how far these families have to go and travel just to have their child seen, just for a checkup, just to have their child seen. The other day, I put a post out and I asked questions. I want to hear all of your stories. Tell me, what are you living with right now? Some of the stories are like this. I drive 14 hours round trip to see a pediatric doctor, and that could be every month, every 2 months. There's people who travel who will fly to see a rheumatologist, a pediatric rheumatologist, because they don't have one near them. And another problem that they also have is this costs money. When you're talking traveling, hours upon hours, parents have to take off work. They don't get paid. Their children are missing school. It costs money for hotels. They all say they have to stay in hotels. And this is on top of, paying for prescriptions, and that's another topic, we're not going into, but how expensive treatments are on top of this. And then you put a child who can't hardly move and they're stiff when you're sitting in a car for hours, right? And then that affects the child. So I hear stories just about how it is it's stressful. It puts strain on relationships, and how just difficult this is. It breaks my heart. It breaks my heart to see these families who don't have it like my girls have had it, right? I understand, because see, once, like Andy said, once damage is done, is irreversible. Is irreversible. And if these children cannot get the diagnosis, if they cannot get the treatment, the care, they're living another day in pain, another day that their joints are getting worse, their eyes are getting worse. Do you know that this disease can also affect the organs? And just the other day on Facebook, one of our J family warrior kids lost their life due to this disease. It's imperative that we get these children to doctors and they don't have to travel. And this disease has caused families to go bankrupt. This is so detrimental. It's important for our families. Thank you.
So let's move to the doctors. I'm curious if you could help us understand more. There's seems to be no shortage of patients. So why does there appear to be a shortage of doctors, both adult and pediatric rheumatologists?
Should I answer first? Yeah. So I think there are a number of reasons. First, as I mentioned earlier, a lot of physicians of all sorts are part of the baby boomer generation that is rapidly getting towards retirement, and so we have a problem of people leaving the workforce very rapidly. Also, we have a shortage of people entering the workforce, and there may be a number of reasons for that, but I think one important one is that although you've heard these stories, these conditions, at least as you go through training, are still relatively under-recognized, under-taught. The experience that Michael had with his mentor that said, no point in going into that field because there won't be anyone to treat, is still sometimes the attitude that some folks have. So to deal with that, we have a number of initiatives with the American College of Rheumatology to try to introduce medical students, residents, all through all stages of training to the field of rheumatology. I think for me personally, I entered training just as the first medications called TNF inhibitors that have really made a major impact in treating both juvenile and adult patients came to market. And I saw it as an outstanding opportunity to do something that rheumatologists before me were just not able to do because of lack of effective treatments. So we need to instill that passion. People don't go into rheumatology to make lots of money. They don't do it because it's glamorous. They do it because they have a real passion for helping people. And we need to do a better job of sharing that passion with them, and I think we're trying to do that.
I think there are a number of perceptions that exist. One is that doctors like to make money. While we don't dislike it, it's not our sole motivation. As it happens, the studies that have been done on medical students show that those who select high-paying career areas typically make that decision during medical school. But people go into rheumatic disease care and other types of autoimmune disease care, including psoriasis, when they're motivated by the complexity of disease, by the types of patient populations they want to serve. And they make that decision later. For men, it typically is in their first year of residency. For women, it's typically in their second year of residency. So it seems to be that a critical time is during residency training. That's the time after medical school when you do your general training. And another aspect of that is that where there is pediatric rheumatology specialty electives available, only 25% of people take those rotations. I don't know what the answer is to why they are not used more. It may hearken to the misperception that they'll not be dealing with, quote, rare diseases. We need to do a better job of branding ourselves, I suppose, and advertising what we have to offer. And that we live in an era where there are remarkably good treatments and people have really quite good outcomes for the most part. I think I'll leave it there for now.
So
I have lots to say about this.
So Dr. Hendricks, I want to ask you one more question. You mentioned HR 1859, and I wondered, though, as a final question, if you had other suggestions for our audience as to things they could do to ensure that we would get more rheumatologists in the field.
Thanks, Ann. One of the points that comes to mind is that the National Health Service Corps can deploy physicians to underserved areas. These are deemed physician shortage areas, really at any point in their capacity, meaning that somebody who is subspecialty trained may be deployed as a generalist. That's a concern, because obviously that doesn't use that person to the maximum of their potential, and we could do a better job of deploying resources where they're most needed. So I think to the policymakers here, I would advocate that we do include some type of language that ensures that subspecialists who are trained to provide that level of care are used in that capacity and not sort of demoted, if you will, to a more generalized use.
Great. So thanks to our panelists. We're now going to open it up for questions. We have people here with mics, so just raise your hand if you have a question. Yes, over here.
I was kind of curious if Andy's, the number of visits per year is, oh, thank you. Is that normal, like 3 to 4 times a year? Excuse me. Or if, you know, in certain cases there's going to be more visits, and also, is it the type of disease where it's going to be scheduled visits for the majority, or are there also cases for there to be like unscheduled visits where if there's a program where doctors are traveling, could they set it up so that they can set up their visits in one specific area for, you know, 4 times a year? Or is it going to be like you can't schedule it that way?
That's a great question.
Good question. Mainly, I used to see my doctor much more frequently than 3 to 4 times a year, but because a lot of them see so many patients, it's really hard for them to schedule around it, and you really can't have a unscheduled visit. Most of the time, they are completely overwhelmed with patients, and they can't fit you in. And traveling-wise, I'm not sure. I know my clinic that I visit does not do that.
So I don't know if one of the rheumatologists wants to answer as well as to the frequency or how the flares and that sort of thing.
Yes, so all of these diseases are chronic diseases that have a tendency to flare up, and there's very little in terms of predicting when that happens. So what Andy said is exactly right. When people are stable and well controlled in their disease, it can go, as you heard, when people are having flare-ups, they need to be seen right away. And if that rheumatologist is states away, that can be a big problem. I know in Boston, you can practically walk across town on the heads of doctors. There's so many. But even a neighboring state like Maine, there used to be a rheumatologist, I was told recently, that used to fly in a King Air up to the northern part of Maine, because the northern part of Maine is actually a 10-hour drive from Boston, and do a clinic once a month. And if you happen to get sick, and it wasn't that once a month, what are you supposed to do?
Yeah. So other questions? Wow, very, very quiet group. You guys must,
And
yes?
you know, one thing I might add to what we have been talking about the shortage in number, it's not just a number problem, it's also a distribution problem. So all of these specialists tend to aggregate in big cities where there are training programs and where the research is going on. And so one of the lovely things about this piece of legislation is it's tied to the National Health Service Corps, which by its very mission it has a goal to send people to the areas which are underserved and most in need. So yes, we have to increase the numbers of pediatric rheumatologists and other specialists, but we also have to get them to the places where they're in greatest need. And that's part of, I think, what makes this particular solution an attractive one.
That's a great point, Dr. Harvey. Well, thank you to our panelists. I think you must have done a great job in articulating the problem, and thanks to each of you for being here with us today. We really appreciate it, and to ACR for being great partners, and thank you.